So when we are doing gynecological surgery, we can do for benign conditions and for malignant conditions. So if we talk about benign conditions, the most common surgery will be when you are doing simple ovarian cystectomy. Then sometimes you have to remove benign adnexal mass. Then if there are complications of PID, then you have to do surgery for them also. So pre-operatively, you should take a full history, perform physical examination, and then you should know the results of some investigations like what is the hemoglobin level, urinalysis, pregnancy test, and pap smear is up to date or not. In all of those countries, they will request regular pap smears or which can be by conventional method or by the liquid-based cytology. Then another question is that what will you check before proceeding for surgery? You should say consent. She has received antibiotics, and what is the plan for anticoagulation, because these are the complications you are going to face. What type of incision should be given? Lower transverse incision for young women with benign adnexal pathology. Lower midline for PID or when difficulty or cancer is anticipated. Then you will have to give lower midline incision. You will start with this one. And if you find some unexpected pathology, then you can always extend this lesion. Okay. So let's say that we are going to do a simple ovarian cystectomy. What are the usual indications? Benign simple ovarian cyst that persists or causes symptoms in a younger woman, which means that the female is less than 40 years, then this is called simple ovarian cystectomy. So what type of incisions we can give? We can give low transverse, and you should know about the instruments also. Sometimes they will ask you that pick up the instruments you are going to use. So you will say, I will need a knife, electrocautery, Gillies forceps, abdominal retractor. I hope you have seen all of them. This Balfour. Regarding these forceps, many different types of forceps can be used. Then you need swabs, you need suction. Then you need Babcock forceps. Then you need this Makindo. This is most commonly used. You know, this sharp one scissors. I will show you the pictures also. Or still scissors, needle holders. Then you need non-braided sutures such as Maxon. Maxon is now less commonly used, so we are using PDS mostly. Then you should have straight Mayo scissors also. The Kendo is the one with very sharp. It is sharp, and you know the blades are smaller than those in the Mayo scissors. So how do we do this procedure? We will, once the patient is under anesthesia, you will pack bowels into the upper abdomen and identify the abnormal adnexa. The operation should be done in such a way that as much ovarian tissue is preserved as possible, because even if a thin strip of tissue is saved, this patient will not need HRT. Okay, she can produce ovums from there, so no need for any HRT. The capsule of the cyst is opened with great care in order to avoid rupturing the cyst itself, and the edge is held with Babcock. The capsule is separated from the cyst and normal visceral ovarian tissue with a combination of blunt and sharp dissection, and the cyst is removed. The edges of the capsule, they should be oversewn with a non-braided suture such as Maxon or PDS, to ensure that there is a low incidence of post-operative adhesions and good hemostasis. It is important to remember to inspect the other ovary before closing the incision in layers. So you should know about cystectomy, the adenectomy. No one is going to ask you surgery for PID. They will not ask you, but in case they ask you, because PID is quite common, they will ask you what are the indications for surgery in cases of PID. You will say that if suspected pelvic inflammatory disease with a tubo-ovarian abscess, or there is a failure to respond to conservative or medical therapy, if patient has developed generalized peritonitis, if she is in septic shock, Then uncertainty regarding the diagnosis. Because maybe now patient started with PID, but maybe some fascia has been involved, maybe some gangrene is forming, which can be due to group A beta hemolytic streptococcal infection. So you need to remove that tissue. So surgery for acute PID is a life-saving procedure where the goal is to drain any pus collection and preserve ovarian function if possible. Definitive surgery, for example, to remove hydrosalpinges prior to IVF is usually best done once the acute infection has resolved. As during acute infection, your patient can have excessive hemorrhage because there will be inflammation of the tissue. So what type of incision we will give? Lower midline incision, because it can be extended if necessary. Then uh, which instruments are helpful? You need a knife, electrocautery, Gillis forceps, abdominal retractor. They can use different types of retractors, like simple ones, tourniquets, swabs, straight Cocker's forceps, and Russian forceps, heavy pedicle clamps, like main goat or zeppelin. These are the larger ones. We use them during hysterectomy also. Then McIndoe's scissors, needle holder, then Victral. You can use one or two. It should be on the round body. That's how it is coming, you know. The straight needle we are using only for the skin. Then straight Mio scissors. Regarding procedure, two main types of surgical treatments can be performed. First is laparotomy with drainage of any pelvic abscess. For example, in a young patient who still wants to have children, then second one can be laparotomy. So it can be done with total abdominal hysterectomy and bilateral salpingo-oophorectomy. It can be done in an older patient whose family is complete and patient is in septic shock. So during laparotomy, the entire peritoneal cavity should be packed. You should first of all, you know, sometimes they will ask you that you are doing a surgery, what will be your first step? You must say that you will open the abdomen and you will inspect peritoneal cavity, and that is what you do routinely, right? So examine the entire peritoneal cavity thoroughly for abscess which is found. If it is found, it should be opened and irrigated. Wash out the peritoneal cavity with the normal saline which is at body temperature, otherwise your patient will go into hypothermia. At the end of the you have to do that at the end of the procedure. Then a relook procedure may be required after 24 hours if the sepsis doesn't respond to any treatment or if there is recurrent collection of the pus. So that's all you need to know about the benign procedures. So now we will talk about hysterectomy. So can you tell me that you have just told me about the abdominal hysterectomy's indications, and you should remember that this is the most common procedure. Sometimes they will ask you that what will you like to tell the patient before starting hysterectomy. So you should start with the definition that this is a surgical this procedure means that we are going to remove the uterus surgically, or only if we can remove the body of the uterus. If this is a viva, then you should say here we are going to remove uterine corpus in the case of subtotal hysterectomy through an abdominal incision. It is important to say that the procedure when you are removing the womb through the abdominal incision, then this is abdominal hysterectomy. Otherwise, you know, you can do it from down below or you can do it laparoscopically. So regarding indications, abdominal hysterectomy is still the most frequently performed gynecological operation on women. The majority of the hysterectomies are performed for symptomatic or large uterine leiomyomata. Other more rare indications are endometriosis, adenomyosis, uterine or cervical cancer, ovarian and tubal cancer, pelvic inflammatory disease, and abnormal uterine bleeding. The prolapsed uterus is most often removed through the vagina. Why? Because it is already hanging down, so you don't have to open the abdomen and pull this all up and then remove. So then they can ask you that what is the difference between total or subtotal hysterectomy. So the evidence accumulated so far doesn't indicate a difference in outcome regarding the post-operative recovery, sexual function, urinary tract and the bowel problems, or pelvic organ prolapse between the total and subtotal hysterectomies. The decision depends on the post-operative fate of the remaining cervix. Whether the regular pap smears will be done. If you will leave the cervix behind, yes, you have to tell the patient that she still needs cervical screening. Then second thing is that you need to tell the patient that this area of the cervix it is left behind, so maybe some endometrial tissue is still inside the cervix. So patient can have bleeding on during at the time of the periods. She will say that she doesn't have a uterus, but still it can bleed from the cervix. So it depends that then the surgeon will see that there is a technical difficulty of removing, for instance, due to tight adhesions, and the need for speedy surgery due to unforeseen intraoperative complications. Then another gray area, and the examiner can ask you questions like this: that should ovaries be removed before the age of 45? Your answer is that this debate is still continuing. The results of the follow-up of a large cohort of women who had hysterectomies for benign conditions showed that removal of the gonads protects against cancer of the ovary and of the breast while increasing the risk of hypertension, coronary heart disease, and osteoporosis. Our decision should be made in consultation with the patient and her family, considering the existing family risks for breast and ovarian cancer and the prospects of patients of regularly taking estrogen in the years to come following operation. So you will have to counsel the patient, and then you should tell her the benefits and the risks of doing this procedure, and then you can proceed. So whenever they will ask you about surgery, you should divide that into different parts. You should say, don't give them the headings, just tell them that I will in the first of all I will counsel the patient about the procedure, then I will make some pre-operative preparations, like I will obtain a valid consent, I will obtain an informed consent. It is important that the patient and her family understand the operation and its consequences. Intra and post-operatively possible complications, they should be presented and discussed in details. The mortality from hysterectomies for benign conditions is very low at 1 to 2 in 1000 cases, but death remains a possible, though it is very remote, but it can result from the procedure. So if the patient asks you what is the chance of death, you will say just it is the incidence is 1 in hundreds of thousands. So another very real issue is the emotional response that women in all cultural contexts they may develop to the absence of the uterus. So since this organ is a symbol of femininity and fertility, and it its loss may have even impact on the female's self-esteem, and possibly it can cause destruction of her position in the family. So these are the emotional problems. So you should tell them that it is not going to affect their libido, and it is not going to make them to change them into a man. This is a wrong concept. So first of all, you are going to see her mood, then you need to see what is the clinical and the laboratory evaluation. You need to do certain investigations. You have taken history, clinical examination, so you will detect all the pathology which needs to be optimized before surgery. Investigations you can choose according to the condition of the patient. For sometimes you will have to do chest x-rays, ECG we are doing for all patients, pelvic ultrasound scans, and sometimes you have to do MRI. Why MRI? Because it will help you in deciding that what should be your route of surgery and what should be your surgical field. and how much area is involved. So it will help you in planning, in identifying the pathology and choosing the correct approach. So many patients are anemic if they are having chronic blood loss, like in cases of heavy menstrual bleeding. So the extent of problem should be evaluated by a complete blood count and corrected to at least a hemoglobin concentration of 10 grams per deciliter. So by hematinics like oral therapy, iron therapy or transfusion prior to surgery. Kidney function test and random or fasting blood sugar levels, they should be checked. Pre-operative pregnancy test is in fertile women and a recent pap smear, they are also part of the workup. Women over the age of 40 with a history of irregular vaginal bleeding, they should have a pre-operative endometrial histologic examination to rule out malignancy. That's why if the patient is having heavy menstrual bleeding, if you remember, we need to take the pathology, okay, take the sample. Endometrial pathology should be recognized, which you can do by people or you can do that by conventional DNC. Okay. So then HIV test should also be done. Um, it is better if we can do that. So on the pre-anesthetic visit, while all patients they should be seen, special care should be taken in to inform the anesthetist of all potential problems detected during the pre-operative evaluation. Further investigations or additional treatments they might need to be done after the pre-anesthetic visit. Then preparation of bowels in some cases. So a laxative such as Physacolil, it can be given early in the morning before surgery and it will contribute to empty the rectum before surgery. More extensive preparation should be done if possible bowel involvement during surgery. For instance, if there are extensive adhesions, endometriosis of the rectovaginal septum, if it is anticipated. The type of anesthesia it should be decided by the specialty team, but you have to say that, okay? Anesthesia will be decided by the anesthetic team. So it will be usually general anesthesia due to good airway control, good relaxation and a flexible duration corresponding to surgical needs. Then again we need to give her IV antibiotics, prophylactic ones. So you can give a single dose of prophylactic cephalosporins of the first or the second generation just before the anesthetic induction. It has been shown to reduce substantially the infective complications of surgery. And if the operation lasts longer than 3 hours, then you need to give another dose. Regarding the surgical technique, the first point is how your patient should be positioned. So for an abdominal hysterectomy for benign disease, the patient is usually positioned in dorsal decubitus. She is lying on her back. The right-handed surgeon should stand next to the left side of the patient to use better his or her dominant hands. A left-handed person will stand on the opposite side. So it depends that how they like to carry out the surgery, from which side of the patient. So shaving of the pubic hair should be done on the operating table. This is often not necessary and may be replaced by clipping. Clipping is nowadays clipping is recommended. So shaving opens small excoriations in the skin which depending upon the duration of the exposure may harbor bacteria and increase the risk of wound infection. So skin should be prepared with antiseptics from the upper third of the thigh or just under the costal margin. So to vulva and vagina, the vulva and the vagina, they are cleansed with non-irritating antiseptics. The patient is covered in sterile surgical towels. A Foley's catheter draining in a closed bag, it should be inserted in the bladder and it should be left in situ until the next day. So in abdominal hysterectomy, keep the catheters for at least 24 hours. So after that, what happens? Students, they will start describing the skin incision and everything. No, you have to do examination under anesthesia. Sometimes the anesthesia offers opportunity to evaluate the pathology again under optimal conditions to enable more adequate operative plan. So then Choice of incision. Most of the uteri that are not longer than postpartum ones, they may be removed through the transverse suprapubic incision. Like if they are up to like 12 weeks, 13 weeks, they can be taken out from the transverse incision. So usually a fenestrial incision is given. So and if the organ is larger, then you will have to give midline subumbilical incision, and possibly extended above the umbilicus, it would be suitable if the size is larger. Then technique of incision. For a fenestrial incision, the skin is opened transversely with a scalpel in a slightly arcuate line. It's not straight, it is slightly curved and some 3 cm above the cranial margins of the symphysis pubis. So subcutaneous fat is incised in the same fashion. Some surgeons they prefer electrosurgery for fat incision and hemostasis. Yeah, that's fine, no problem. Okay, take your time, please. Okay, so are you free now? Sir, if you are busy, then you can leave, no problem. Okay, okay, that's fine. Yeah, okay, that's fine, no problem. Yeah, so, yeah, okay, yeah, okay, yeah, that's fine. Okay, then I think let's start with the station, okay? So I will upload this one so you can read from here there. So let's talk about this one, okay? You will take 2 minutes, then we'll talk about her. Okay, you can start, please. All right. Yeah. Okay. Yeah, I will accept. Yeah. Uh, yeah. So for how long I will have to take antibiotics? So, what about my pain control? How we will do that? Because it's a big procedure, right? Because you said it is going to take a long time. It must. Okay. Okay, that's fine. So, when can I start eating? Okay. So, when can I return to work? When can I, I am a teacher, when I can start working again? Yeah, after 4 weeks, okay? You can say after 4 weeks you can go. Okay. So, when can I start driving? Okay. So, when are you going to see me again? Okay. Okay. That's fine. Okay. So, all of these questions I have asked, you have to tell the patient yourself. Okay. You will tell her that what is the benefit, what should be done, and what can be done for her when she can do all of these things. So, please tell me another thing. Yeah. So, yeah. 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 Okay. So, then what can you tell me about enhanced principles of enhanced recovery program? Because whenever you will do any surgical procedure, you should add one line. I will follow principles of enhanced recovery. So what are those principles? Can you please tell me? Okay. Don't worry, this is a simple thing, but yeah. So don't worry about it because everywhere healthcare and especially the surgical care is becoming very costly. So they introduced certain principles of enhanced recovery in 2012. They say that enhanced recovery it aims to reduce the physical and psychological impact of elective gynecological surgery on the patient to facilitate a more rapid recovery, shortened length of stay, and return to normal activity. So complications and readmission rates are comparable to or better than those seen in the other conventional programs. So the principles are that they will involve the patients each and every step. What they will do, they can do certain things before the procedure. So pre-operatively, what they will do appropriate risk assessment of the patient's health and fitness for a surgical procedure. It should be time to allow administration of any optimization of any problems identified. This so that you can reduce the complications and mortality intra and post operatively. So it will start in the community before referral to the hospital because maybe someone is a diabetic, has some medical conditions. So all of these should be addressed so that patient is fully fit to undergo surgery. So then what you have to do that comprehensive verbal and written patient information should be given. So that is the purpose that we are giving patient information leaflets to them before surgery because they should understand the procedure, they should know what they will expect, and then we have to give them education that how they can reduce the need for pain relief, and we want to improve the experience of the patient stay in the hospital also. So procedure specific information and consent they can be very helpful. So consent should be taken in a very should be given in a very simple language, and they should explain that what will happen, what she should expect. So pre-operative planning of the day of discharge is another key element of enhanced recovery. Patient, relatives, care providers and the community agencies they can ensure that the appropriate support is available for the planned discharge by ensuring information about length of stay following the procedure. Then perioperative. On the day of surgery, dehydration is avoided by reducing the period of starvation to 2 hours. Yeah. Which one? Ah, yeah. No problem at all. Just a minute.